by the people, for the people, the gathering to get healthcare now, chapter 13. These are examples of the organization of the medical teams. We have an example of 4 physicians who put together IPAs with some ease. They all had a clear idea of the nature of an IPA, and each recruited from 50 to 100 physicians in about 60 days, and then turned the IPA management company into an organization that could get into the marketplace. What makes it possible to organize the IPA rapidly, and what does it take to get business for the IPA? If you want to slug it out with the big companies that control the healthcare funding, including the government, you must have capital, and the IPA can't scrimp on initial investment monies. Most of the organizers have invested about $1 to $2 million in the development of their IPA. Usually, the physicians own most of the interest of the business. They recognize that there must be insured business for the IPA, and there must be willingness to move patients to the IPA's contracted health plans. Medicare has entered this IPA arena, and they assign patients to these IPA physician organizations in ACO contracts. They contract to share savings with the IPA, and they follow the model of the Medicare Advantage plans by sharing between 50 and 60% of the savings. The elements necessary for further development of successful IPAs are: 1, physician leaders who are well respected, articulate, and caring. Member physicians who put the patient first and treat her or him like family. Creation of the right sized teams. Adequate capital for the operation. And finally, patience. The first step is having enough primary care physicians who are willing to influence their patients to buy health plans that contract with the IPA they control. A typical PCP practice has from 1,500 to 2,000 patients. That patient load must be shared with physician extenders who can attend to the health screening of the well people and the worried well people, for the physician to have enough time to attend to acute and chronically ill patients. Over 3 years, it should be possible for the doctor to convince about 800 to 1,000 of his or her patients to move to the IPA contracted health plans. It's not possible, however, for insurers to add new patients to his or her practice in such a way that it does not simultaneously reduce the quality of care. The patient-physician relationship will be disrupted. To get the enrollment numbers needed for the IPA to be profitable, the physicians need to direct their patients to the IPA's best contracted health plans. About 400 to 500 of potential patients will be seniors who choose Medicare Advantage plans and traditional Medicare. The rest will choose commercial health plans through their employers and associations. The IPAs need 30 primary care physician practices to have a large enough population to enlist the support of a specialist team and a local hospital. If the current insurance system changes dramatically and the IPA's Medicare Advantage plans and employer-based plans reduce payments, then the plans will still need to perform under budget to earn performance bonuses. Care coordination, peer review, and quality assurance must be done better than is being done and for less money. In a zero-sum game, it is a question of who gets less, physicians or facilities. The second step is to recruit 2 specialists in each of the following 15 categories: cardiology, radiology, gastroenterology, general surgery, nephrology, neurology, OBGYN, orthopedic surgery, ophthalmology, otolaryngology, pediatrics, pulmonology, podiatry, and urology. Cardiovascular surgery, neurology, oncology, and other subspecialists are special teams in themselves and are usually available in only a few tertiary hospitals. They form their own teams, and IPAs contract with them to be more effective in the care of critically ill and chronically ill patients. Part of this second step is in knowing the referral patterns of PCPs as they exist currently, and then changing those patterns to enable the group to operate as a team. Referral patterns are chaotic in groups that are not purposely organized to direct patients to specific specialists and facilities in which these specialists are well practiced and supported. Disorder in the existing system is apparent, and it leads to higher cost and lower quality care. The third step is contracting. The contracts between an IPA and a physician are long and written in technical language. And over the years, the contracts have gotten longer because of new laws and regulations governing commercial insurance, Medicare, and Medicaid. Some states have introduced a standardized physician credentialing application. This helps by saving physicians the need to complete a different form for every insurer. The standardized applications are about 20 pages long and require 12 additional documents: the current resume, the list of continuing medical education credits, a copy of a state medical license, copy of the current DEA certificate, copy of the current liability insurance face sheet, copy of the current liability claims history, copy of the medical board certification or eligibility, a copy of the medical school diploma, copy of the residency certificate, a copy of the ECFME, a copy of the CLIA, completed and signed W-9 form. Most physicians keep an electronic version of their completed standardized application and the 13 supporting documents on file so that they can easily respond to new contracts. This process makes the job of IPAs much easier when they are required to verify each physician's credentials for the contracted insurers. The cost to each insurance company or hospital to collect the information and to verify the credentials is approximately $250 a year per physician. Sometimes insurers transfer this cost to the physicians or to the IPA. The contract between the physician and the IPA can be made easier to read and credentialing easier to complete. The full agreement, including the required attachments, can be put into booklet form and distributed electronically in PDF format. It's the same for every member. The physician keeps the booklet for his or her files and returns to the IPA only the signed declaration page, the standardized application, and the 13 supporting documents. This can also be done electronically. Changes to the agreement with individual physicians never happen. If this were otherwise, then IPAs would be unable to easily get agreements with health plans.